Thank you for joining us today. I'm Dr. Kelly Ferraro, a Denver Health palliative medicine physician with a background as an internist, and I'm joined by Dr. Carol Fowler, a family physician who's now a palliative medicine physician at Hope West and SCL Health, St. Mary's Medical Center in Grand Junction, Colorado. We know that times are stressful, and we hope that learning more about scripting difficult conversations can help you as a clinician. Next slide. In the next 15 minutes or so, we'll hope to cover these topics. Let's jump right in. Next slide. Why are these conversations so important? First, we know that patients and their families are thinking about these topics. It's up to us as clinicians to start the discussions. These conversations allow patient goals to be expressed and, when possible, met. Shared decision-making. When a patient shares their non-medical goals and you use your clinical expertise to recommend a medical treatment plan that helps focus on these goals, leads to the best possible care. We also know that one early conversation can save the stress of uncertainty later. Next slide. You've hopefully watched our colleague's presentation on helping a patient pick an MDPOA. Once that's done, the next step is to talk about goals. We find it helpful, when time allows, to focus on what general quality of life means to a patient, and then get into specifics. Next slide. Knowing who your patient is as a person can help you provide them with the best possible care. This is something well known to primary care clinicians everywhere. It's also the basis of shared decision-making. The patient is the expert in what they value in their life. You're the medical expert who can help tell them which medical treatments will help them achieve these goals. The only way to know their goals is to ask. In the outpatient setting, you can start advanced care planning before your patient's visit by asking them to think about and document their values. Next slide. Once in your appointment, you'll want a script to make sure that you hit all of your key points while still staying time efficient. Here's one example we'd like to provide, which can help you start and guide the conversation. First, you'll want to set up your conversation. Something like, I'd like to talk about what's ahead and do some thinking in advance about what's important to you so that we can provide you with the care you want. Is that okay? Then you'll want to understand what the patient knows about their illness. It's never a good start to discuss how the patient wants to approach their treatment before they understand that they have the disease. Third, share their prognosis. A few tips here. It's very tricky to predict time, so we recommend sticking to broader timeframes that allow planning while conveying that uncertainty. I worry you may have just weeks to months left. If that time is short, is there something you'd like to focus on? It's also important, after asking permission, to discuss certain likely scenarios as part of their prognosis. For instance, I worry that if you were to get COVID-19 with your COPD, you'd be very likely to need intubation. After this, you'll want to explore key topics and close the conversation. We've given you this slide as a reference, and we'll offer COVID-specific examples coming up. Next slide.
We're now going to build on the framework of the outpatient guide discussed by Dr. Ferraro. In the next two slides, we reference guides from VitalTalk and Ariadne Labs for conversations with inpatients who are COVID-19 positive. VitalTalk and Ariadne Labs are two nationally recognized leaders in palliative care and in teaching clinicians effective communication skills. Though similar in structure and purpose, the guides differ slightly in language and style. Try them both and pick the one that suits you best. I really like that the VitalTalk authors of this first guide came up with the acronym CALMER, because it reminds me of how unsettling, even scary, this time is for all of us. I think that it is very important to acknowledge this to ourselves and to name it for our patients. CALMER stands for check in, ask about COVID, lay out the issues, motivate them to choose a proxy vote MDPOA, and talk about what really matters. Expect emotion, and record the discussion. You'll notice that the first part is take a deep breath. It reminds me of the advice that we all had as medical students responding to a code or starting an ACLS algorithm. First, check your own pulse. So it's important to take a moment or two to plan these conversations before you head in to see the patient. And it's important to use a script or roadmap just as you would an ACLS algorithm. It keeps you on track, helps you avoid missing something critical, and reduces your stress. In this slide and the next, you'll see similarities to the conversation guide discussed by Dr. Ferraro earlier. Here are the common threads. These are dialogues. They seek to learn what the patient already knows before you share information. And they make a recommendation that flows from the patient's values and goals. Both guides have pauses built into them for acknowledging emotion, using language such as, I worry, this is hard, I wish things were different. While not explicit in both guides, it's important to document the conversation in the chart, referencing any forms you complete. That helps your patients and your colleagues down the road. Next slide. As in the previous guide, it helps to start with setting up the conversation. Acknowledge how difficult this current situation is. Seek permission to have a discussion in order to get the best care for the patient. You'll notice too that the conversation does not begin with asking about specific treatments and procedures. So what is asked first? Invite the patient to tell their story before you share medical facts. Begin by asking, for example, what the patient is worried about most. Next, explore the patient's values. Critical questions to ask are, what is most important for your loved ones and medical team to know if you were to get very sick? What abilities are so important that you can't imagine living without them? Who would speak for you, and how much do they know? You'll want to normalize that people don't all think the same way about medical interventions, and to invite the patient's views. You can say, some people are willing to go through a lot. Others focus primarily on comfort. How do you think about this? Last, the guide weaves together the patient's perspective with your medical information so that you can make a recommendation regarding options. In this guide, there is language for two paths, an aggressive treatment path and an alternative path of providing only those treatments that would be helpful in achieving the patient's goals. Close with a recap of what you've heard, offer thanks and continued support. I heard you say blank. Thank you for sharing this information with me. We will do everything we can to help you and your family through this. Next slide. Now let's navigate the uncomfortable for a bit. We all struggle when patients want care that we think won't help. Finding a middle ground can be useful if that's the case. This might mean proposing a time-limited trial, for example. Let's try intervention X. We can see how your brother responds in the next few days. I'll keep you up to date with what I'm seeing, and we can talk some more. Is that okay? You can also put this in terms of benchmarks. You can say, if this is effective or not, we'll know by seeing why. We will use that as a signal that it's time to talk more about what might lie ahead. How does that sound? The time may come when comfort becomes the focus of care. You might say, I'm concerned that your brother is just not responding to the treatments the way we hoped. I wish it were different, but I worry that his time is short. If appropriate, ask about the location of care. Where would your brother want to be if his time is short? Let your patients and families know what you are able to do, especially when a cure is not possible. While we can't get your brother better, there is a lot we can do to make sure he is not struggling with his breathing, experiencing pain, or afraid. I will briefly mention that crisis standards of care have also been developed. Our fervent hope is that we will never need them to allocate scarce resources, such as ventilators, ICU beds, hospital beds, dialysis machines, or critical medications. Nonetheless, conversation guides also exist for such scenarios, and these too can be found in the resources noted in the next slide. Next slide. On these websites, you'll find very useful videos modeling these conversations, as well as links to guides in English, Spanish, and a host of other languages. All our best wishes in your conversations with your patients wherever you or they are.